Good afternoon, everybody. I'd like to go ahead and call the Senate Health and Social Services Committee to order. The time is 1:32 p.m., 17th of February, 2016. With me today is Senator Stoltz, Senator Ellis, myself, Senator Stedman. There's other things going on in the building, so the other senators may or may not be here in person, but they'll be keeping an eye on what's going on anyway. We don't have any bills on the agenda today, but for any formal action, but what we have before the committee is a hearing on the health insurance market. It's been in the press quite a bit the last few days, or last few weeks, and it's been a concern of the citizenry for quite some time. So we've asked the Division of Insurance to come in and give us kind of an overview of what's going on. Primera, MOTA, insurance carriers, and then also a representation from the Alaska State Hospital and Nursing Home Association to try to give the committee kind of a broad brush view of the situation so we could decide what, if any, action we can take, or if we have to have further hearings and to try to deal with this. The intent today is to lay some data on the table again, and what I'd like to do is ask the presenters to try to stay away from acronyms as much as possible. Although we use them a lot and throw them around a lot, the folks at home might not be as familiar with them, and if they can't follow the presentations, it doesn't help as well as it should. So if you could, even though it might take a little bit longer to not use them, it'll be more effective. What I'd like to do is invite the Division of Insurance representation to come forward and start with that as the hearing. We'll give them about 45 minutes, see how we do. If we can get through this presentation in 45 or quicker, then we'll go on and have followed by Primera, MOTA, and then the hospital group, and there's a presentation on that, so that'll probably take 15-20 minutes for that. So I'll try to watch the clock, and we will have the appropriate reward or punishment for anybody that falls asleep.
Mr. Chairman,
as we get into this. Senator Stoltz.
have you built in an occasional inquiry into the 45-minute timeline?
Inquiries from?
Myself or?
We will always have time for Senator Stoltz's questions, along with
I'm lucky I'm
the other
the one
committee
guy in the
members.
building that does.
No, we'll have that. What I'd like to do is try to hold as many as possible, generally speaking, in the presentation till the end, but the presentation, particularly this one, is going to be too long. So if you have a question, just let me know and we'll get it put on the table.
Can I just maybe bring
Senator
out a couple of
Stoltz,
things
would you
before
like-
we start, Mr. Chairman?
Would you like to speak, Senator Stoltz?
Yes, sir.
A couple of questions. Maybe you can punctuate them if they're already part of your presentation. One is a better understanding of the 80th percentile rule and how that's applicated, part of Alaska Administrative Code, and the effectiveness of ACHIA, the Alaska Comprehensive Health Insurance Act, or agency, I believe. Trying not to acronym. And I think I'll have one other, but if those are part of their presentation, maybe they can even be a little more descriptive.
If the director could roll that into her presentation when she feels it appropriate to respond to that generally as we roll through that, so you kind of stay on track to your presentation.
Mr. Chairman, on that ACHIA, it was the general effectiveness, or is it outlived? And then last item is the whole interplay between the Affordable Care Act and lastly, it also interspaced the size of Alaska's market and how that interplays. And I think I won't have to interrupt if you can incorporate those, trying to help facilitate your agenda on time, sir.
Okay, there is slides on membership and so on and so forth data, so we'll take that into account along the way. If you could introduce yourself for the record, who you represent, and then your trustee aide could introduce himself and who he represents.
I'm Lori Wing-Heyer. I'm the Director of the Division of Insurance for the State of Alaska.
And I'm Fred Parity. I'm the Deputy Commissioner of the Department of Commerce, Community, and Economic Development.
And the chair does recognize the pecking order within the division, but sometimes when you have complexities within the division, the division director has fairly substantial detail knowledge that the other members do not have. So
I cheerfully defer, Senator.
I did not, through the chair, reference either the 80th percentile or ACHIA in much detail. So if you'd like, I will answer Senator Stoltz's questions first.
if you would like.
As respects ACHIA, ACHIA is still active. There are very few members left in it, as most of them have left and gone to the Affordable Care Act. We have looked at the study of why, and some of them have just said that they're uncertain under the Affordable Care Act, they're scared, and quite honestly, the premiums in ACHIA for health care are more than what you would expect under the Affordable Care Act. The reason we have not petitioned to close ACHIA is because we do not have a market for medical supplements, particularly drugs. And if we closed ACHIA, we would be shutting down those markets, or that particular market, for Alaskans, and that is the heaviest usage of ACHIA at this particular time. We've also looked at ACHIA as a possible vehicle when King versus Burwell, before the ruling came out, and we thought that perhaps we would have to have our own exchange. And when there have been discussions of the state looking at a Section 1332 waiver, we've also let ACHIA enter the discussions of would it be useful. But right now, the main reason ACHIA exists is because we don't have a market in the state of Alaska for med sups, for the drugs, for people that are in need of them, to supplement their insurance.
And the 80%?
The 80th percentile. That regulation went into effect approximately 13 years ago, and it was done for the concern of consumers who were getting huge balance billings on what they saw as what should be covered. And so through public comment and concern for citizens, the regulation was adopted that simply said, it's 2 lines within the administrative code that said that payments shall be made at no less than the 80th percentile. And of course, that is basically out of network when it's not a preferred provider agreement between your insurer and a provider. And there has been a lot of concern raised by various parties, both on the healthcare providers, the insurers, brokers, and constituents, that it's time for that to be re-examined. And we have suggested that we look at the data that's being presented again after session and decide if it is indeed a regulation that has lived its usefulness. The concern is that once again, people would get large balance billings because the insurers would not be required to pay at the 80th percentile, or under the Affordable Care Act and the advent of insurance as it has developed or evolved, would our constituents be such that they would not get large balance billings.
Okay. And we thank you for your quick answers, and we're
Can I follow up on that?
briefly, but we got a big
I don't
docket
understand.
today.
These are kind of central parts of it. The 80th percentile was really, it was now about a dozen years ago, was a consumer protection, and now it's, it seems to have flipped around, or at least that's the perspective with the provider costs and the insurers. We're getting eaten alive, and the consumer with our small market, and that was my other size question, our size of our market. Specialists can name their price, and is there, I guess, is that something you're going to cover in your presentation as well?
Through the chair, Senator Stoltz, no, I don't cover it in my presentation, but that is the concern, that the flip side is that the physicians that are not in provider agreements are setting the 80th percentile. For as many calls as I get from insurers, I get a call from a physician saying, that they cannot live within a provider agreement. So there's two sides, and we need to get to the bottom of it as the division and decide if the 80th percentile has outlived its usefulness and is no longer, and it is actually a detriment to rates.
Okay, so let's move on with our presentations, and what we'll do as a committee is come back after we're done with our presentations. We may have other things that maybe include the 80 percentile, maybe other issues that surface, and we'll come back and revisit those. But my concern is we put this kind of a broad brush view on it so people at home can follow what's going on. So when we delve into things like the 80% rule, they understand kind of why we're there and what's going on. So let's go ahead and build a mosaic, and we'll start with the director.
I think it's important, particularly in the media the last few days, that people understand that the mission of the division is to regulate the insurance industry, and the primary responsibility for us is to protect the to protect the Alaska consumers within the industry. We have a statutory responsibility to review and approve rules, forms, and particularly rates. And when it comes to rates, we look for rates and perform an analysis to determine if they're inadequate or excessive or unfairly discriminatory. We look at past performance and accurate prediction of the future historical statistics. We justify the filings, be it an increase or a decrease. And all of this is done to make sure that the company is solvent and able to pay the claims when they are presented to the insurer. And the same is done regardless if it's a property and casualty, a workers' compensation, a surety, or a healthcare or life insurer. The division does not have the statutory authority to deny a rate, an increase or a decrease, because of the financial impact it would have on one's pocketbook. And that is unfortunate because we are very sympathetic and we are empathetic to the cost of healthcare as it has been in the last 3 years, particularly in the individual market in the state of Alaska. We have seen dramatic increases, and we do understand it has the impact it has had, particularly on the 20% that do not receive premium tax credits in the state of Alaska in the individual market. And I will try very hard not to use acronyms, but I do have on a slide. If I do get off, as we do tend to talk very much in acronyms.
A partial list.
A partial list of the acronyms that we use. And some of the things I do want to talk about that have impacted us in the last year are the 3 R's, also the transition of the non-grandfathered plans, the 3 R's being risk assessment, the risk corridor, and reinsurance, which were risk stabilizing mechanism built into the Affordable Care Act. They are also going to impact us as we move into 2017 because 2 of those mechanisms will sunset and no longer be available to the insurers, and one of those mechanisms has not performed as expected. The other that I want to talk about is the non-grandfathered plans. I want to hit on those just a little because those plans will eventually move into the ACA plans, and it will build our market a little as far as the number of enrollees. It's not a huge number, but we would expect those enrollees to move into the ACA qualified health plan or the Affordable Care Act qualified health plans. Just a brief timeline. In March 23, 2010, the Affordable Care Act was signed by President Obama. And under that, if you had a health insurance plan that was in effect prior to that date, you were allowed to keep it. And those are what we call the grandfathered plans. So we have no reason to believe that the majority of those plans will ever come in to the Affordable Care Act. Now, there are certain conditions where one can see that those plans would come in. If there's a significant reduction in benefits, eliminating substantial benefits, raising coinsurance, raising co-payments, adding or tightening annual limits. If they do change the plans to those degree, they would have to go to an Affordable Care Act or a qualified health plan. But unless they change the grandfathered plans, those plans could remain as is and would not come into the pool that we talk about so much as far as how many enrollees do we have, why is it so small, will we get new members? And part of it is, again, because of those plans. If you like your health insurance, you can keep it. If the plans were in place prior to March 23rd, they can remain like that into perpetuity. When people started to enroll, the end of 2013, there was concern. There was frustration with the exchange. There was concern with the pricing. And President Obama made the decision that if you had insurance between the period of March 23rd in 2010 and January 1st, 2014, he allowed you to keep that plan for a certain period. And those are what we refer to as the non-grandfathered plan. And those plans will sunset that this year, except for the small group, and they can continue to 2017. But in the individual market, those plans should transition into the individual market this year. It will enlarge our pool. It's not a significant number, and I do have that number for you further back in the slide, but it will expand our pool somewhat in Alaska. 2014, January 1st, 2014, the first plans became effective. Individual plans and, of course, the small group. There have been numerous changes made to the ACA from January 1st, well, probably going back to 2010, but January 1st, 2014 going forward, and I believe that in 2017 there's over 110 changes made to the plans for 2017. Some of them are going to be small and no one will notice. Some of them can be rather large, but our staff is dealing with them day by day, and we will be ready when the filings are received, and we will be ready for the consumers when they enroll. Again, just a brief recap of the important dates in Alaska and how Alaska, when the rates have come in, when the rate filings have been approved, and where we are today as of October 1st, 2015. The reason I have that date as the very last bulletin is because that's going to become an important date for us as we talk about the risk corridor payment. I talked to you a little bit about the risk corridor payment was one of the 3 R's, the stabilization of the pool. And the insurers that were participating in the individual market were expecting, and I do have a slide to explain it a little bit more, but they were expecting to be reimbursed at 100% of the risk corridor. And the program, for a variety of reasons, it failed, and they were reimbursed at 12.6%. And in the lower 48, we saw several, I believe it was 11, possibly 12 co-ops fail, and several regional insurers and large national insurers struggled when it became known that for the 2014 risk corridor payments, they were only going to receive 12.6%. When CISIO, or the Center for Consumer Information Insurance Oversight, approached Congress to fund the difference, the request was denied. There has been controversy in the U.S. delegation, or the federal delegation. Would Congress fund that? And so far the request has been no. There is hope that there will be enough money to make the 2014 payments. There's hope that there will be enough at some point to make the 2015 payment. But at this time, this is a great concern for the insurers, because as they budgeted and set their rates, they were counting on 100%. And they received, as of right now in 2016, they've only received 12.6.
We're going to have about 1 minute a slide. Stay on schedule.
Okay, stay on schedule. I'm talking faster. The next ones will be numbers.
Okay, that's fine.
The next one, I'm just giving you of who was in the individual, the numbers of who we showed for enrollment. And again, this is just to show you, first off, how many we had in the market as far as Primera Moda, Assurant, and Aetna, and Celtic at the time, and the individual and the small group. This is 14 and 15. When open enrollment closed on January 31st, we show our numbers to be at 23,029 for the individual market for 2016. The next one, I'm breaking it out into the grandfathered and non-grandfathered. So you can see we'll have some movement of the non-grandfathered plans over to the ACA. But again, it's not a huge number. I don't think it's going to, it's certainly not going to double the pool, but it will make some difference into seeing those plans come over, those 2,300 members come over to the ACA qualified health plans. The small group, again, just to show you, I'm listing out these companies because I think it's important to know who we started with. I want to back up just a slide to know that Aetna's gone and Assurant have left the market as of 2016. In the individual market, I know you've read it in the paper, but as of right now, we are down to Premera and Moda servicing Alaska in the individual market, both on exchange and off the exchange. The small group market, we still have Assurant has left. They pulled out nationally, but we do have Premera, Moda, Aetna, United Healthcare, and some others that are writing in the small group market. Sources of health insurance in Alaska. As you can see, we still think that there's about 16% that are not buying insurance. Employer is the largest at 49%, and the other breakdown as where people are accessing their health insurance. And the individual plans is still a small percent of the Alaska market. Healthcare insurance filings. The steps that the state goes through, the Division of Insurance goes through. We are given our authority, we are given our guidance through regulation, the administrative code, and also by statute. Again, the rates may not be excessive, inadequate, or unfairly discriminatory. They must be filed at least 45 days before they're effective, but no more than 6 months. The rates for large groups may be fully experienced. Generally, that means, because it will differ a little bit by insurance company, but they need to be more than 100 members and have their own rating criteria. Filings must be certified by an actuary, be accompanied by an actuarial memorandum, description of the rating formula, and corresponding assumptions. I'm sure you can read this, but it's quite a detailed process. It's long, it's involved. It takes us months to calculate, to review. It goes back and forth to make sure that every box is ticked, every I is dotted, T crossed, and that the rates that are finally released to the public are not excessive, they're not inadequate, and they're not unfairly discriminatory to the citizens of Alaska. And this is the same process that we use. The statute will differ, but it's the same process that we use for property and casualty. Excessive. To give you somewhat of a recap to what is excessive, because people will call and say, but my rate went up 45% and it's excessive. And I have no doubt that to their bank account that is excessive, because particularly in the individual market right now, I don't know anyone that does not think their rate is excessive. But unfortunately, by statute, excessive has to do with the expected cost of the claim, the overhead administration of the insurer. They have to be able to pay the claims, and they have to be allowed the cost to adjudicate the claim, provide claims management, case management, and allowed to make a small profit. Pay taxes as any other business would. And if that's what is in the rate filing and what is determined as to be excessive. Adequate is almost the reverse. They have to be able to cover those costs. And not doing so could lead to a company's insolvency, and that is the last thing we want to happen in the state of Alaska in any line of insurance. Effective rate review. Alaska was one of 43 states that was determined to be an effective rate review by the U.S. Department of Health and Human Services in January of 2012. This allows us not to submit our rates to CMS for approval until we have approved them ourselves, where CMS then has the right to go over our rates, which they do, and they have then the authority to come back, or the right to come back to us and question it. To date, they have not done so. We do have questions with CMS over our rates. We have certainly had conversations with them the last 2 years because of the amount of the rate increases we have taken. This past year, we hired an outside consultant, risk and regulatory consultant, to review as an actuary, to review our rates before they were published or approved. just once again to calm fears, to make sure that the Division of Insurance was doing all we could do to keep the rates as low as we possibly could, but yet to make sure that the companies were in fact solvent. Here's some numbers, and this will include, it's the individual market, but includes the ACA qualified health plans, the grandfathered and the non-grandfathered. You can see where they were before the advent of the Affordable Care Act. The premiums went up dramatically from 40 million to 70 million, but so did the claims. Basically, you're looking at an increase in premium of 30 million, but an increase of claims of 46 million as respects Premera. So when you look at the loss ratio, what that's telling you that in 2014 overall, they were taking in for every premium dollar, they were paying out $1.05 in claims, and that doesn't include administration. MOTA, a very similar story. They went up 30 million in premium, but they also took on $32 million in claims, and their loss ratio, they were paying out $1.04 for every dollar in premium they took out. And I jumped over the small market, but for reasons we can't understand, the small market's performing much better than the individual. The rate increases. Before the Affordable Care Act, with the transitional or the non-grandfathered plans and the grandfathered. And then, of course, the rate filings for 2014, it wasn't a rate increase because it was the original rate filing. And then there was the 37.2 average rate increase and the 38.7 this year. And the next slide shows the same story for MOTA. I'm showing you what the rate increases were for the other insurers. Celtic, we are hoping to, they do have a rate filing open. We're hoping to entice them to maybe do some more in Alaska, but so far they've been uncompetitive because they are still higher than either Premera or MOTA in their rate filing, and they have not really been very open for business, but we are trying to talk to them to see if they would consider writing in the individual market. Aetna, they withdrew in 2016. We never approved their rate in 2015 because we thought it was excessive. Time is one of the Assurant companies. They withdrew in 2016. John Alden is the same story. They are one of the Assurant companies and they withdrew. The risk corridor, or the 3 R's, I should say. We talked about these somewhat. The risk adjustment, one of the 3 R's is to redistribute funds from plans with lower risk enrollees to plans with high risk enrollees. If you can kind of think of it almost as Robin Hood type. But unfortunately, it is not working as well as it is as had thought it would. It is working, but you are seeing companies that are perhaps overall not doing as well, writing to larger companies. And in Alaska, for the fees that were paid, Alaskans paid $33,000 in 2015 and $62,000 in 2016 as our estimate in fees that were paid to administer the risk adjustment. But this has turned somewhat in the way it's being applied because you are seeing the smaller companies who had perhaps the lower risk enrollees end up cutting checks to larger companies. So it's almost having the reverse impact of what was intended. The reinsurance. This is one of the 3 R's of this program that sunsets in 2016. For this alone, we would expect to see rates increase somewhat as the federal government is not going to reinsure the Affordable Care Act, the individual market, the individual or the small group. And this works just like commercial reinsurance would in property casualty or life and health. There is a base layer of which the insurance companies hold the claims. After that, then the claims are ceded to the reinsurance. This year, our estimates of what Alaskans paid, I show as far as what were paid as far as the premiums. To the reinsurance, it's a healthy amount, but the amount that has been paid by the Act it has decreased from 14, 15, and 16. It's still a huge amount, and again, that plan is over this year, and the insurers will be forced to assume the cost themselves. The risk corridor, this is the one that I just spoke about, that it has not been successful, and it was not set up. It sunsets in 2016. The program overall, I don't want to say it's a failure, but it did not work as intended, and the federal government chose not to fund it to the gap, so to speak, for 2014. I don't know what they're going to do in 15 or 16, but the insurance companies to date have only received 12.6% for 2014, and there's really no guarantee of what they're going to pay for 15 or 16. They are committed to paying 14, but again, as with many things in the ACA, we're going to have to wait and see where the funds come from to pay 15 and 16 of the risk corridor. It is due the insurers. If you talk to CMS, they say we will pay it, but you can also hear an argument of they don't quite know where the funds are going to come from or how long it will take to accrue them to actually pay the insurance companies. Healthcare, I found this study, and this was done by the Healthcare Commission, and we asked why our healthcare premiums are so much. And you have to look at, if your healthcare premiums are so much, what are your healthcare insurance premiums based on? And a lot of it is the cost of healthcare. And part of that is just the actual cost of healthcare, and part of that is the way we utilize healthcare. People in Alaska are not always the best at how we utilize healthcare. There's a lot of emergency room visits that don't need to be. People don't go to primary care doctors sometimes as they should, and we probably need to do a better job of educating people on the proper use of healthcare. It's not that people shouldn't go. No one should be denied access, but utilization is a key factor in the cost of healthcare. And the other is that we need to admit that our costs are amongst some of the highest in the nation. And that to fix this problem, we're probably going to have to all get together at the seat at the table and determine that maybe not everyone is going to get what they want, but we all should walk away with a smile, and that means the providers and the insurers and the constituents. That it's somewhere we've got to come to a happy medium on what the cost of health care should be, as well as utilization. Things that will drive the rates in 2017, and these aren't necessarily Alaska specific, but the cost of health care that I just talked about and utilization. There are some changes to the essential health benefits. They shouldn't impact Alaska too much, but there are some changes to the essential health benefits. The CMS, or the actuarial value calculator, on the cost sharing structure. We now have 3 years of data, which makes it a little bit more stable for us. There's the continued migration of the grandfathered and particularly the non-grandfathered plans that should enter the individual market. There is a concern of the insurers merging and exiting the market. I mean, we lost Aetna in the individual market. We know Assurant has left the market totally. United Healthcare, not in Alaska per se, but they've said in the lower 48 they're exiting the individual market. Aetna and Humana, there's a merger pending. Cigna and Anthem, there's a merger pending. This could all impact us indirectly in Alaska. And we're going to need to keep our eyes and ears to the ground to see if it's going to impact us in a good way or a bad way. And right now, we don't know. There's always going to be ongoing uncertainty with the Affordable Care Act as it's continually being challenged. There's always someone. Right now, there's House versus Burwell is still up there. And as long as there's uncertainty, we're going to have to watch it and see how the reaction is to the Affordable Care Act. We've already talked about the reinsurance, the risk corridor, and the adjustment. And there's changes in fees and taxes. The Cadillac tax has been postponed to 2020, so that won't impact us. But there are changes in fees and taxes that could impact us. In Alaska, again, the cost of health care, we will always struggle with limited providers and the challenges with provider networks. We're a rural state, we're a huge state, and being able to bring health care to rural areas will always be expensive and a challenge. The individual market may have settled somewhere around 22,000. It may never get any larger than that. We know right now that we settled at 23,000, but that's 23,000 have enrolled. It will probably drop some when it comes to payment time. So I think 20 to 22,000, that may be as large as our individual market ever gets. Adverse loss experience, it's not a healthy market. We've seen that in the numbers in the claims. And the national cost drivers in the slide that I just went through, those, we're not immune to those. They could impact us. It's just a little bit too early to see exactly how the mergers and some of the others are going to impact us. Solutions. We've talked about a Section 1332 waiver. We know that Colorado has an initiative on the ballot. We're watching Minnesota, Hawaii, and Massachusetts. This is basically, in just real simple, it's saying that we're going to be our own ACA. We're going to take a look and say that we could do this better than the feds, but there's a lot of risk with this. And I talk about the risk. First off, it takes legislation. But we have to do this at not increase the federal deficit. We have to offer the plans no less than what someone could get through the ACA. We have to cover a comparable number of citizens. We have to apply to be and be given the authority to run our own program. It's not a simple mechanism, and to date, no one state has been allowed to do it. You can't do it until January 2017. And it's a risk. We already know we have a small pool. So we've looked at it, but it's not guaranteed that it put us in any better spot than we're in right now. But we are following the other states to see how successful they are. And we're certainly watching and keeping our eyes open. It's not something we're ignoring or just shutting the door to. Other solutions. I'm sure you know that there's a draft reinsurance bill being floated around that would replace in some ways the reinsurance of the federal reinsurance, but also look at the individual market and transfer the high-risk dollars or the high-risk claims through the ACHIA program back to the insured market. We've talked about a regional exchange, a compact, and could we basically form a coalition or a compact with other states, particularly in the West, where they face similar challenges as we are. They have large areas, small population, and they are starting to kind of feel the same pains that Alaska has in the past few years. We've talked about combining the individual and the small group for rating purposes and to spread the risk amongst that. The problem is you're going to have small employers that are not going to be real happy when you put the individual losses into their market when they're performing so well. So, I mean, we're looking for solutions that might make it easier. And that, Mr. Chairman, is about all I have, but I'm certainly here for questions.
Okay, if we can go back to slide 15.
Yes, sir. Okay.
Projector maybe goes back. Slide 15 talks about, the rate increases under the Affordable Care Act on 15 and 16. Does the department have any feeling for attractions for 17, the trends in place? Where would you be surprised and not surprised at the end of the day?
Mr. Chairman, we don't have the filings in, but looking at medical trends, looking at knowing that the population is somewhat stabilized, looking at, we know we're going to lose the reinsurance and the risk corridor not paying, I think we will see a rate increase. I don't know that it will be as dramatic as what we've seen in the past, but I can't see the rates decreasing.
Okay. That's fair enough. Senator Stoltz.
Yeah, a fairly quick one, Mr. Chairman. Ms. Heyer, on the available services, one of the issues, I hadn't thought about it for a while until I met with some hospital people yesterday. They brought up the CON, and it jarred my memory. And is that a possibility to increase competitiveness and availability of service and reduce costs? Have you looked at that, or just in the broadest sense?
The CON.
Certificate of need.
Oh, I'm
And
sorry.
the competitive issue, acronym, I'm sorry.
Through the chair, I'm sorry, you threw me for a loop there. Through the chair, we have not looked at it, to be honest. We certainly can.
I appreciate it. Thank you. And again, it jarred my memory the other day when it was brought up.
Senator Ellis.
Thank you, Mr. Chairman. You talked on slide 27, regional exchanges, partnering with other western states. I've thought for some time that there could be some cooperation and cost savings there potentially down the road. How far along are those discussions?
Through the chair, Senator Ellis, they're not very. I mean, we've talked with, at NAIC level, there are, I think, 5 states in the east that have started to talk about doing an exchange, and we have reached out to the western states, but they're not beyond just discussion stages at this point. Washington and Oregon are a much healthier market than we are, so we are truly trying to talk more to the Wyomings, the Montanas, the Idahos, possibly Dakota, those that we see would more match with our needs. But even until this past year, they did not see the rate increases until 16. They were fairly stable in 15. And it wasn't until this year that they started to see the rate increases that Alaska's seen.
And Mr. Chairman, not a follow-up to that point, but in one of the previous slides, and I don't have it right here in front of me, you noted the relative advantage that healthcare professionals in Alaska have over insurers. And then you made a later comment about the relative small number of healthcare providers per capita in Alaska. Are there other factors in this imbalance between insurers and healthcare providers in Alaska?
Through the chair, Senator Ellis, I think that in Alaska there's a couple of things that we face when it comes to providers. You find the providers in Anchorage, Fairbanks, Juneau, but you don't find them in rural Alaska. And no one wants to chase the providers away. But I think what we are seeing or what we are hearing is that the cost is much higher, that people are leaving the state to access health care, going to Seattle, they're going to Phoenix, they're going to wherever to seek treatment. And we would like to keep those costs, or we would like to keep the physicians in Alaska. So we're trying to find the balance of where we could keep the services and the health care in Alaska, but yet somehow we've got to get physicians and providers to the table to say what's driving the insurance or driving people out of state is because insurance companies are saying we can take you to Seattle to get the treatment for much less. And I don't know how to get everyone to the table to agree on what the proper cost is, but I think to keep the community that we do have of healthcare providers, somewhere that discussion has to be had as to how do we keep everyone that we've got and not lose our healthcare community, but not to see it disappear strictly because people are going to Seattle to get service, because it's cheaper to buy a plane ticket than it is to get the service in Anchorage or Fairbanks. I hope that answers your question.
Any questions for the director? Any final comments on the presentation before we jump to the next one? I know you're...
Well, Mr. Chairman, just
Senator Ellis.
thank you, Mr. Chairman. Not another question, but just a statement. It relates to way back at the beginning, slide 2. The division does not have statutory authority to deny rates because of the financial impact to the consumer. And our constituents, the consumers, and I appreciate this being stated clearly and emphatically, forthrightly, because I've maintained for a couple of decades that the system was out of balance, not just between insurers and doctors, but the division, and it's really on us as policymakers that we have never addressed, and it's been previous governors and previous division directors who have resisted any change at the legislative policy level to redress this imbalance. the lobbyists and executives for the insurance industry, health insurance industry, have given a thumbs down to any kind of changes or even discussions at the legislative level in providing statutory authority, rate review authority, for the department to, or the division to consider the financial impact to consumers. It's not the end all, it's not a magic bullet, but bringing more statutory authority to the division and a better balance of consumer interests and private sector company influence or interests, I think would serve our constituents better than the current system. Thank you.
We have any comments from the deputy before I come all the way over here? Just got something good to say. Even if it's not so good, we want to hear from you.
Mr. Chairman, Senator, on perhaps a lighter note, during my legislative service, I remember a floor debate in which someone said that insurance is like a hospital gown. You think you're covered and you're not.
Okay.
Thank you.
Well, we try to make sure people are covered.
There you go.
With that, thank you. We'll have our next presenter come forward. Representatives from Primera, please. And we are on track for timing, so we're okay.
We feel the whip.
And if you can introduce yourself for the record, who you represent, and then speak to the, I guess, the presentation or the subject matter in front of us.
Thank you, Mr. Chairman, members of the committee, and thank you for the opportunity to provide comments today. For the record, I'm Sheila Tolman with Primera Blue Cross. Primera has operated in Alaska since before statehood, since 1952, and provides coverage to over 109,000 Alaskan residents. We offer coverage to individuals and families, small employers, large employers, as well as offer services to the larger self-funded employer groups. Now, I'm going to provide comments regarding the changes to the market that are impacting Primera's individual plan premiums, describe our overall individual pool experience, and also a policy approach to stabilize the individual market. With health reform in 2014, the major change to the insurance market was guaranteed issue to all individuals without pre-existing condition exclusions. This provided access to several thousands of individuals to the private coverage market, which has been a good thing. And Primera priced products estimating the impact of the uninsured purchasing coverage for the first time. However, we experienced a significant influx of new enrollees with very high medical costs. These were individuals leaving the high-risk pool, the Alaska Comprehensive Individual Health Insurance Association, or ACHIA. That pool shrunk by half, and we expected that most of those have moved into the private market, as well as the closing of the federal pre-existing condition pool, which was also another kind of a high-risk pool, part of the Affordable Care Act. So many more of those ended up moving into the private market, and in 2014, Primera lost over $13 million in the individual market. For 2015 and 2016, Primera had approximately 37% and a 39% average rate increase for those individual metallic plans, which impacted around 8,000 enrollees that we had in 2015. And again, for 2015, we are expecting to have the same or more in financial losses in the individual market, based even with those premium rate increases. And then to say it differently, Primera is taking in, on average, $713 in premium per member per month, but we are paying out claims at $919 per member per month. So this is really just demonstrating the very high claims costs we are experiencing in the individual pool. The individual purchasers are also older. On average, they're now about 40 years old compared to what we saw pre-2014, where it was more, the average was around 35. So all of these changes are having a dramatic impact on the individual market. While the guaranteed access to the private coverage, regardless of health status, is available and has increased more people to come into the market, in a very small-sized market like Alaska, there are not enough healthy individual purchasers to offset the costs of enrollees with these very high medical needs. And we now have an unsustainable market with 2 years of almost 40% rate increases for both Primera and MODA. Premium for a 40-year-old in Anchorage purchasing a silver or a gold plan is between $860 to almost $1,000 per month. And while the majority are receiving subsidies in the exchange, there are some that are not. And Premera has approximately 1,600 individuals that are purchasing coverage off the exchange who are not getting subsidies and are paying the full freight of the premium. The federal 3Rs, which the director just spoke about, were designed to minimize the effects of adverse selection, especially for these first 3 years, to help insurers kind of understand the new entrants into the market and to help stabilize the premiums. But they are really insufficient at the very high end of the claims costs, which is what we are experiencing in Alaska. And it's just not enough to help spread the risk when you have so many high claims costs in a market that is too small. So what can be done? The key to addressing the situation is to create a large enough pool to spread the costs of these members with the significant medical needs. Premera and MOTA are supporting the concept of a state reinsurance program to help stabilize the individual market from these significant premium swings, and we've also met with some legislators to discuss this approach. The concept would spread the claims from the highest cost medical conditions, and we're talking about like long-term chronic conditions such as kidney disease, heart failure, certain things like that, across the entire insured market, which would utilize the state's high-risk pool, the Alaska Comprehensive Health Insurance Association. So the claims costs from the individual market from these individuals would be spread across a larger base and paid for using the current high-risk pool assessment, which is, again, paid for by the insured plans. And by doing this, we will be able to help lower the rate of the premium increase that the individual market is bearing. This solution, this concept, was actually implemented by ACHIA, the high-risk pool, in 2013. You might remember in 2013 there was a lack of child-only policies being available in the health insurance market, and this solution was implemented via legislation in 2012 to utilize ACHIA in the same way to help spread the costs of those individuals across a broader pool, and so those policies were continuing to be issued in the market. Using ACHIA, the reinsurance program for the individual market could be implemented efficiently, since ACHIA already has experience implementing this type of pool and with minimal to no administrative costs, since that infrastructure already exists. Premera and MOTA have submitted data to the Division of Insurance and to the high-risk pool for a study which would evaluate the impact of this proposal on individual premiums as well as the assessment, and we are continuing to refine and work on some of these details related to that study right now. The reinsurance program would not only also help address the premium increases, but it would also stabilize the market, which can potentially attract new competitors into the individual market. And it can also provide some financial certainty for consumers about their health insurance without these drastic swings in premium. We are very concerned that these continued exorbitant rate increases, which are needed to cover the rising medical costs, are actually driving the healthier individuals out of the market, resulting in an ever-shrinking pool to cover these very high costs, and this is just not sustainable. Premera is committed to the individual market in Alaska, and we do look forward to working with you to create a sustainable market for Alaska residents. Thank you, and I'm happy to answer questions.
Thank you. I'll ask basically the same question. You know, looking forward, can you give us an inclination of what you see in 17 and 16, I guess, as we try to Ouija board the future with premiums?
Thank you, Mr. Chairman. I think we would expect that given the losses, even with the rate increases we've put out there, that we would still expect at a minimum the same sort of rate increase for 2017 under the current conditions.
Okay. Any other question? Senator Stoltz, you had a question?
Just a technical one. I noticed there were prepared comments, and I didn't see in the packet. Is that something? You said a lot of things. I didn't take notes. Can we have that on the record?
All right, we'll get a copy of our prepared notes if we could for the committee.
Thank you. That's all I had.
Okay. Hey, next up, with enthusiasm, representatives from MOTA. And we're looking pretty good on time, so. remember you boys from down in the entryway. Introduce yourself for the record, who you represent.
For the record, my name is Jason Godey. I'm the Director of Alaska Sales and Service for Moda Health.
And for the record, I am Craig Anderson. I'm a Senior Vice President and the Chief Actuary for Moda Health.
Okay, if you could give us, I guess, Moda's view of I guess, what we're struggling with here in the state, we'd appreciate it.
Okay. Well, I will kick us off here. We appreciate the opportunity to be here today, Mr. Chairman. Thank you for the opportunity. Moda is very committed to the Alaskan market. We've been here for 12 years now, and personally I've worked for Moda in Anchorage for 11 of those years, so I've seen it almost from the beginning, and it's been an interesting ride, to say the least. And we're up to employing 12 people now in our Anchorage office. We just expanded a medical customer service unit there within the last 6 months, so we're very proud of that. Currently, we administer the state dental contract. We also work with Central Peninsula Hospital on a pilot program to hopefully control costs. You may be hearing some more about that in the future, but not today. Moda was an early believer in providing Alaskans with consumer choice and access to health care through the exchange market. And on that note, I would like to formally introduce to the committee Craig Anderson. He is our Senior Vice President and Chief Actuary. He oversees our exchange markets in Alaska and Oregon.
All right, thank you, Jason. I would just like to reinforce what Jason said about our commitment.
Introduce yourself just for the record so they have it on the recorder.
Okay. Once again, I'm Craig Anderson. I'm Senior Vice President, Chief Actuary for Moda Health. And I have some written comments which I'll submit after this. And I do want to just reinforce what Jason said about our commitment to the Alaska market and our willingness to work with any interested parties on the financing of healthcare for Alaskans. Although much of the news lately has been focused on the individual market in Alaska, I think it's important to keep, and along those lines, the rate increases and the limits of choice for consumers. But I think it's important to keep that in perspective with the entire medical market in Alaska. And in the United States, the majority of people get their health care through employer-provided coverage, and that's true for Alaskans as well. As you saw in an earlier slide, over 50% of Alaskans do access health care through an employer-sponsored health plan. And the vast majority of that health coverage sponsored by groups is self-funded health care too, or self-funded plans, like the state of Alaska employees have. The reason I think that's important is because much of that health coverage is not impacted as greatly by the ACA, because the Affordable Care Act primarily has impacted the individual and small group lines of business. You've also heard earlier, healthcare coverage in general is more expensive in Alaska than in Oregon and Washington, where we also do business. There are well-documented differences in costs between Alaska and other western states that show that costs are between 30% and 60% higher in Alaska for similar services. To address these growing cost differences, we have seen a trend, as the director mentioned, in something called medical tourism, where people are leaving the state to get discounts for services. But I think those programs also have economic and clinical implications to Alaskans. In addition to the high cost of services, there is also the trend in cost. That is, how much costs increase year over year is higher in Alaska than we see with national averages. So that just compounds the problem that I mentioned. And some of the reasons for the cost being higher, and I think we've touched on these earlier today, one of them is that the providers tend to have significant leverage over insurers compared to some other western states when it comes to negotiating rates. The utilization of services tends to be higher in some of the rural areas in Alaska than we've seen elsewhere. And there's just a scarcity in some areas of healthcare providers, and that creates a bit of a supply and demand scenario where, of course, that causes costs to go up too. So currently, the Alaska individual market is somewhere between 20 and 22,000 people, and that's just roughly 3 to 4% of the total population in Alaska. With the expansion of coverage to the federally facilitated exchange, the number of people with coverage in the individual population grew from 13,000 people roughly in 2013 up to 23,000 in 2014. So there was quite an expansion there. And MODE has been a strong supporter and participant in the expansion of individual coverage through the Affordable Care Act. The expansion of the individual market has been difficult nationally on many insurers because the morbidity of the population is worse than what we expected, and Alaska is no exception to that. Part of the concern is that there's relatively a small number of Alaskans that are in the individual market, and that creates a small pool to spread the risk. So one way we are addressing this is the work that Ms. Tallman mentioned earlier, and that is on a state reinsurance proposal, and we're doing that in collaboration with the Alaska Department of Insurance, ACHIA, and Primera. And we are very supportive of this concept as a way to help the predictability of the individual pool when it comes to setting rates. The 3-year implementation of the expansion of the individual market under the Affordable Care Act has not gone as planned. Without the full funding of the risk corridors in 2014, early losses have caused financial strain on MODA and has brought increased regulatory scrutiny as well. As a result, we've seen carriers leave this market and existing carriers, including us, sustain losses as we strive to price our premiums to cover the expenses. So to address this, we do need to work together between consumers, providers, the government to help control costs and ensure that the program is viable in 2017 and beyond. In spite of these uncertainties, the individual market has grown as a result of the ACA in Alaska. And even though there have been high rate increases for the carriers participating in the exchange, hhs.gov published some encouraging facts that I thought I would share with you. One of them is that 89% of Alaskan consumers who signed up through the exchange qualified for an average tax credit of $534 per month through the exchange. And 57% of Alaska exchange enrollees obtained coverage for $100 or less after any applicable tax credits in 2015. And 86% had the option to do so. So in conclusion, again, I appreciate the opportunity to testify at the hearing today. I want to emphasize that MODA is invested in the Alaska health insurance market, and we're available to work with anyone on solutions for controlling costs for consumers. At this time, I'm happy to answer any questions you may have.
Do we have any questions from MODA representatives? Seeing none, thank you for coming in today. Next up, Soltberg, if she could come up when she has time. And we have about 25 minutes, so I think we're okay. Looking at your number, the total number of your slides. We'll have a brief Eddie's. back on the record. If you can introduce yourself for the record, who you represent. We've got 20 minutes and about 15 slides, so we should be fine.
Thank you, Mr. Chairman. Apologize for the brief technical issue. For the record, my name is Becky Holtberg. I'm the president and CEO of the Alaska State Hospital and Nursing Home Association. And I have the unenviable task of coming up to close out the day to tell you why healthcare costs are so expensive in Alaska. And I think maybe to give you a framework for how we believe we can address these costs in the future. So a little bit about Ashna. I won't spend much time on who we are. I think you all know, but we represent more than 65 hospitals, nursing homes, and other healthcare organizations. There are members and associate members, and we employ over 10,000 Alaskans. I also want to note that hospitals are one part of healthcare spending, so I'm here. I really could have my counterpart at the Alaska State Medical Association here. We have hospital costs, physician costs, therapy costs, many costs that go into that aggregate that we end up calling healthcare costs. So healthcare costs are not just an Alaska problem, as this chart illustrates. The graph shows U.S. healthcare costs compared with healthcare costs around the world. And as you can see, our healthcare costs are significantly higher in the United States than they are in other industrialized countries. There are many reasons for this, and I wouldn't have time or really the content knowledge to go into all those reasons, but I will note that this is a problem across the country. And I think it's, as we talk about our healthcare system, it is a market-based system, but it is a market-based system that has really had such significant influence by government that it's really hard to parse out what some of the causal factors of cost increases are. Just as an example, our employer-based health insurance was really a result of wage controls in World War II imposed by the government that led to the modern employer-based healthcare system that we have. And also Medicare and Medicaid pay for a significant portion of our national health care spending, and those are our government programs. So when we talk about this, there is a significant role for government simply because of the government involvement in the healthcare system. So I would also note that because of this number, and because of a number I don't have on this screen, which is the rising cost of Medicare, the Medicare Trust Fund is expected to be exhausted by 2026, that there are some major changes happening nationally in healthcare. We have not yet seen those changes. So that's one of the reasons I think our costs are still accelerating, while costs in other parts of the country have started to grow at a lower rate. So why does healthcare cost more in Alaska? In the interest of time, and I think in deference to you all, you've heard the reasons from other presenters. So workforce costs are higher. Recruitment, licensing is difficult in Alaska. Our licensing framework sometimes makes licensing a challenge. So the labor pool is smaller and wages are higher. Just geography, which I think several other speakers alluded to, scale, small population, which again several other speakers alluded to, and provider payments are certainly higher, which I think was also noted. I would add one, though, which is the regulatory environment. Hospitals and nursing homes are heavily regulated. There are huge federal compliance burdens. We also have state compliance burdens, and every time we add an administrative cost, we add to the cost of healthcare. So those are kind of the simple reasons, but for every complex problem, there's an answer that is concise, clear, simple, and wrong. And so I would say that to go back and address the individual reasons for each of these things may not really solve our healthcare problem. We need to look at this problem in a different way. And the things on that previous list are really symptoms of some problems that I would call system-level problems. And we have to understand and get to the root of these system-level problems if we're going to address the high cost of healthcare in Alaska. I've just outlined 4 systems, and I'm not going to talk about them all, in the interest of time. But I'll talk about a couple of them. Health insurance system, the disconnection of patients from the cost of their care, where when things tend to be free, we consume more of them. So as we talk about utilization tends to go up when people don't have a linkage to the cost of their care. Payment system. We have a payment system where providers are paid based on volume, based on the more things they do to more people. That's what payments are based on. Payments are not based on outcomes, which is quality, cost, and perhaps customer satisfaction. So we have a payment system that rewards volume, and so we get volume. And so we have to look at the payment system. We have social systems. This is one I won't talk about, but we have very different cultural expectations of healthcare. that are at the root of some of our utilization patterns as well. We expect a lot of healthcare whenever we need the healthcare. We don't like very often for it to be told what is an effective or not effective treatment. So we have some cultural and social expectations that drive care. And again, regulatory systems, and I won't go into that conversation because it would take all afternoon. But we have a system where we want to contain cost, but then especially on the federal level, we add to the administrative burden almost monthly, or I would probably even say weekly, and that does drive cost. So we're getting the healthcare system that we want, and if that's a little bit of a provocative statement, I kind of intended it to be that way, because we are getting the system that I think that we think that we want, but there are unintended consequences of what we want. Unfettered access all the time to unlimited healthcare is going to drive an expensive system. So sometimes we can't. If we want something to change about healthcare costs, we're going to have to make some hard choices. So I'm going to talk just for a few more minutes, and then hopefully leave some time for questions about those first two systems, the health insurance system and the payment system. So this graph shows you the cumulative increases in health insurance premiums and workers' contributions to those premiums contrasted with their earnings. So basically, to summarize this graph, what it shows is that the increased cost of health insurance has eaten up much of the wage gains for workers over this time horizon. And that also employees are bearing most of the burden of the cost of increased premiums as employers shift more of those costs to employees. So this is leading to a dynamic in the health insurance market, which is the growth in high deductible health plans. Now, the growth in high deductible health plans is an effort to connect people to the cost of their care. Employers are moving increasingly to these plans, and I'm sure the representative insurers could speak to this much more eloquently than I could, but for a couple of reasons. They're cheaper for the employer very often. They're better, and so as costs go up and employers look to manage costs, they move to these cheaper plans. But they're cheaper because they tend to turn employees into healthcare consumers, more informed healthcare consumers. So they reconnect them to the cost of their care. So I think in Alaska, we do have high deductible plans in the small group market, and in I guess what I would consider almost the private sector market. We have not seen the public sector in Alaska move to these models. So we have public sector plans that really have not changed very much in the last, I would say, 10 to 20 years. And I think that then again, if we're looking at health insurance as a way to reconnect people with the cost of their care, but the public sector really has not followed this trend, I think that's something for us to consider. So moving on to the payment system and how the payment system could change to affect cost. This is a kind of a risk continuum. On the far left side of this chart, you have fee-for-service, which is our payment system now. That is per unit payment based on volume. So if you go into the hospital to have knee surgery, you're going to get a charge from the hospital. You're going to have broken down within that charge all the individual charges from the hospital. You're going to have a charge for an anesthesiologist. You're going to have a charge for a surgeon, and those are all going to be unbundled, separate charges. So that's what we have now. There is no provider risk in fee-for-service. Providers just bill what they do. There's no risk. On the far right of the spectrum, you have what's called a global budget, which is for a given population of people, an insurer or a collaborative is given a sum of money, and they must manage within that global budget. So suddenly, the provider or provider group or insurer group, whichever the group is managing this population, has a lot of risk. And so suddenly, utilization really matters much more. Quality matters much more if you're incentivized financially by quality, which very often these types of of systems are. So there's significant provider level risk, but the provider and the payer and the patient suddenly have aligned goals. And those aligned goals are high quality care at the lowest possible cost. Whereas in the fee-for-service environment, that kind of alignment does not exist. So as we move, and so the continuum, and I won't describe all the boxes on it, really is showing that you don't just jump from one to the other, but there's some movement along this continuum of adding quality incentives or adding payment reform where the provider is bearing incrementally more risk, but again, we're getting closer to that alignment. So why am I as a hospital where things have been representing hospitals where things have been, relatively good, talking about these payment changes, and it's because that Medicare has said that Medicare is changing. Medicare is moving from a volume-based system to a value-based system. They have put a stake in the ground. And hospitals, some providers cannot afford not to take Medicare. Hospitals take all patients through the emergency room regardless of ability to pay. And for hospitals, Medicare is such a significant volume that hospitals will always take Medicare. So Medicare says they're moving. So we believe that's going to have significant impact on hospitals and on how we move into this value-based payment. So Medicare is doing two things. They're saying we're putting a stake in the ground, moving from volume to value. And oh, by the way, we're going to cut your payment as well. So 9 Alaska hospitals are taking about $591 million of reduced revenue over a 15-year time horizon, and that's not including some recent revenue reductions. So we're having to live within our means more and facing an environment where we're going to be in, where our payment's going to change. So this is just a sort of a graphic illustration of Medicare's movement. Category 1 is on this volume to value continuum. Category 1 is where we are, fee-for-service, no link to quality. Category 2 and 3 is where Medicare is going by 2018, which is fee-for-service with a link to quality or alternative payment models that are still built on a fee-for-service framework. And Category 4 is the long-term goal, which is a population-based payment, which is what I described earlier. Global payment is one type of a population-based payment. So we haven't started moving here yet, but I really think the question for Alaska is, are we going to go down this path of volume to value or not? And if so, that has significant implications for a large payer like the state of Alaska with both commercial volume and Medicaid. So I'm wrapping up here, final 2 slides.
You got 10 minutes, so we're fine.
Okay. So this is the new challenge that we have is to meet the triple aim, and the triple aim has been described a lot of you in healthcare as kind of the goal of healthcare and healthcare systems, and that's 3 things: improving the individual experience of care, reducing the per capita cost of care for a population, and improving the health of population. So it's really kind of a cost, quality, service goal. And if we can do all 3 of these things, then we're going to create a system with better care. It's important to note that one of the key parts of the triple aim is reducing the per capita cost of care. And in a lot of things, cost and quality have always have a direct link, and they don't always in healthcare. If you look at data, the parts of the country where healthcare costs the most are not always the parts of the country that have the best quality outcomes. And so we have to look at this as a three-legged stool. We need all 3 of these pieces in place in order to have a highly functioning healthcare system. So I think we're going to be facing a world where increasingly we need to look at the triple aim as a goal, where payments are going to be more and more based on quality, and where healthcare providers are going to assume more risk for the health of a population. So what's the implication as providers, and I guess as a state? And this is the dock analogy. The dock analogy is we're standing on this dock, and the dock is fee for service. That's where we are now. And there's an island out there, and it's called value, and that's where we know we all need to be. But you notice it's kind of foggy, and there's no boat. And so I think the challenge for us as providers and for us as the state is we have a business model built on where we're standing right now. We have this aspiration of maybe getting to a different place where we have better outcomes. How are we going to get from here to there when it's foggy and there's no boat? And I think the way we're going to do that is working together. It's going to take time. Business models don't change overnight. But if we carefully plan this transition, I believe that we can get to a place where we are getting better value for the healthcare dollars spent, high quality care, and where Alaskans who maybe, as some speakers stated, going outside for care are returning to get care here. So it's not time to jump off the dock, but it's time to start figuring out how to build this boat. It's time to prepare for this transition. As I stated before, in an industry where government already has such a significant role, there certainly is an ongoing and important role for you as state policymakers in helping us to design this transition. So with that, I will thank you and be available if there are any questions.
Any members have any questions?
I think all the metaphors were targeted at the chairman.
I did notice the dock, the fog at the end, that we don't want to walk off of a dock, take a long walk on a short dock. So, with that, thank you for your presentation. And if we can have the Division of Insurance Director come forward with bouncing enthusiasm to finish up the meeting today. Thank you for your taking the time to put your presentation together and bringing it forward to us and going through it along with the other presenters today. I'll talk to the committee members, find out kind of where we want to go with this issue. It's an evolving issue and definitely a concern, as Senator Ellis said, to the constituents we represent. And what I'd like you to do also is just kind of keep the committee informed of this as this progresses, a potential broadening of the pool to try to see if we can, alleviate some of the upward pressure on the premiums, stabilizing the market and keep companies participating in Alaska. And we'll work with the division, as we go through this, because I recognize that we don't have a silver wand here to just wave it, have a statute and fix much. Senator Stoltz.
Thank you, Mr. Chairman. And I guess as we continue the discussion, I'd maybe like to delve into just even deeper what the size limitation of our market, how that constricts us, and in our ability to be creative, or how much more creative you have to be. That seems to come up time and time again, and just even have the availability to have an insurance player here in the state, whether it's for health care or for risk liability for various professions, and I guess just as we try to do all these things, are we banging our head because of our size of our market at the end of the day?
All right. If the division could help us a little bit with that, and also when you put some of that data together, if you could take a look and see if you can't give us a little bit of analysis on the loss. We went over the loss ratio, but it'd be nice to put it in numerics, because some of the printed reports I've seen talk about 17, 20, 25 people, a very small number of people with large losses that are skewing the loss data. And if we could have some of that for general background and what's publicly available would be the request. So we could, if we need to use it, we can use it at the committee. Any other questions for the division director? We are 3 minutes early. We're going to adjourn today. Thank everybody for coming, especially the out-of-town guests. We're not a scary lot to come talk to. We want to try to help the industry and the department, the division, solve problems.
Thank you, sir.
That's what we're here for. With that, we will take a look at next Monday, possibly at 1:30. We will see by posting the schedule on Thursday afternoon what next week's agenda is. We'll keep the committee members posted. We are adjourned.